Okay, well, it's 8 o'clock. It's a bright, sunny, cold Madison day. So welcome everyone, and I hope everyone is staying warm and safe. I am delighted to present this week's Medical Grand Rounds, and Dr. Sanjay Asthana will be presenting our guest speaker, Dr. Nathaniel Chin. So Sanjay?
Yeah, thank you. Thank you, Lynn. Good morning, everyone. It's a real pleasure for me to introduce Dr. Nathaniel Chin, who is an assistant professor in the Division of Geriatrics and Gerontology. Dr. Chin received his undergraduate and medical education at UW-Madison. Then he went to University of California, San Diego to do his internal medicine residency. After completing his residency, he stayed there just a few years to practice as a hospitalist and came back to Madison to do his geriatric fellowship in 2015. After his clinical training, he did additional 1.5 years to 2 years of dementia research fellowship and was hired as assistant professor following his dementia research fellowship. As a faculty, Nate, in addition to his academic and clinical work, also serves as medical director of the Wisconsin ADRC. He's also the medical director of the RAP study, and he is associate director of the geriatric memory clinics at UW Health. He also serves on the board of the Wisconsin Alzheimer's Association. Nate, no surprise, was an outstanding undergraduate and graduate student and actually received a number of awards. Let me just name a couple of them. He received an Academic Excellence Scholarship from UW. He also got the McGraw-Hill Publishers Award. Of course, he got the popular Shapiro Research Award from a medical school and received the UCSD Hardest Working Intern Award in internal medicine. He's also one of the San Diego's top docs when he was practicing there. Dr. Chin is a co-I on 5 NIH grants, and one of them is focused on disclosure of Alzheimer's biomarker results, and that's what the theme of his talk today is. Nate is one of the most sought after speakers in the area of geriatrics and dementia. And just in the last 3 years alone, he has made more than 55 local, regional, and national presentations. And one of the, I think, most distinguishing contribution of Nate to our department and the division, that he has created 89 episodes of podcasts called Dementia Matters. And these podcasts have been downloaded over 200,000 times in all the states across the country, and 28% of them have been international downloads in, I suppose, 80 countries. So you can imagine how popular these podcasts are. In fact, the downloads take place on average 100 times a day. And finally, Nate was just recently appointed to a very prominent national committee, which is an NIA and the National Academy of Sciences Committee. He's one of the 4 members on that, which will be focusing on the implications, clinical implications of Alzheimer's biomarkers research and the Alzheimer's diagnostics. So it is truly a pleasure to invite Nate to make his presentation entitled Disclosing Alzheimer's Biomarker Results in Preclinical Alzheimer's Disease, Why, How, and What We Still Need to Know. Nate, stage is yours.
Thank you for that introduction, Sanjay. These are my Cme Disclosures and Objectives. I'm excited and grateful to be here with everyone, fellow clinicians, researchers, badgers. We can identify the changes of Alzheimer's disease 10 to 20 years before people develop their first symptoms. Despite this, we do not have a cure or true disease-modifying therapy. So with that in mind, if I obtained a test on you that could tell me if you had the first of 2 abnormal proteins that make up Alzheimer's disease, Would you want me to share that result? And today, my this presentation will discuss this very situation. And I ask that as we go through this together, you think about it not only from the perspective of a patient or participant, but also as the clinician or scientist. The topics I'd like to discuss are reviewing amyloid in the context of Alzheimer's disease research, discussing the implications of amyloid disclosure and prior research findings, share with you our preliminary findings from the Alzheimer's Biomarker Survey, and then introduce our own amyloid disclosure study within the Wisconsin Registry for Alzheimer's Prevention. As Dr. Stana said, I do receive grant funding from the NIA, but I have no financial gain from disclosing amyloid to anyone. I'd like to start by thanking the true scientists on our team, Dr. Lindsay Clark, who is a part of the Department of Medicine. She's a neuropsychologist. She is the lead investigator on the Alzheimer's Biomarker Survey, as well as the amyloid disclosure study. Dr. Sterling Johnson is the principal investigator of WRAP, the Wisconsin Registry for Alzheimer's Prevention, which is arguably the most important longitudinal study looking at Alzheimer's disease in at-risk people in the entire world. Claire Erickson is a fantastic fourth-year graduate student who has been an invaluable member of our team since we first started talking about amyloid disclosure. And then lastly, Hannah Rosario is a wonderful study coordinator who keeps us organized, on track, and really in the good graces of the IRB, which we all know is really important in this type of research. So the science of Alzheimer's disease is evolving. And so with that, so is the definition of how we look at Alzheimer's disease. And so I'd like for us to look at it from two perspectives. The first perspective is that of the clinician. And this is Dr. Bob Przybylski, or Dr. P, as most people know him. And he's been a geriatric memory provider for decades. And so the clinician diagnoses patients. The clinician focuses on management of symptoms and care planning because we don't have a cure, and our treatments are really for symptom reduction. So to a clinician, Alzheimer's disease is the cause of our patients' clinical syndromes, be it mild cognitive impairment or dementia. So first we have to diagnose those syndromes of MCI or dementia. And that's really based on clinical history, particularly functional history. And then after that, we then determine that Alzheimer's disease is the probable cause based on clinical factors. That's clinical history, collateral history, and then data from labs, imaging, cognitive testing, and then really ruling out other conditions. And I say probable because this is not a definitive diagnosis. We're fairly accurate in a memory clinic, 75 to 85% accurate, but not where we want to be. And so the second perspective is that of the scientist. And the scientist sees Alzheimer's disease for what it is on the inside of the brain. So a scientist identifies pathology. The scientist focuses on understanding the disease process and then studying interventions to see if we can have a meaningful impact. So to a scientist, Alzheimer's disease is A, T, and N: amyloid protein, tau protein, and neurodegeneration. So a scientist identifies these biological changes of amyloid and tau accumulation in the brain, and then uses that to study cognitive performance and its relationship to A, T, and N, and then other risk factors that may modify that. So previously, we would look at symptoms to determine which people to study and how they were doing, but now that's not needed because we can identify A, T, and N in living people. And as I said, we can actually identify it in people who do not realize they have this disease yet. So it's really important to see Alzheimer's disease through the lens of these biomarkers. These biomarkers allow us to identify pathology. They allow us to figure out which groups of people to study, to see the trajectory of their disease course, and to see which factors hopefully modify their condition. And so biomarkers are an objective indication of a person's observed condition inside of their brains in this particular situation. It has to be reproducible, it has to be measured accurately, and it has to represent the biological process. And so in Alzheimer's disease, This was first discussed in 2010, and then again in 2013 by Dr. Cliff Jack and others in Lancet Neurology. But it became very impactful in 2018 when they redefined Alzheimer's disease, not by symptoms and presentation, but by these biological biomarkers. And so I'd like to walk us through this figure here. And so on the x-axis, we have time, and on the y-axis, we have biomarker abnormality. And so your biomarker becomes abnormal when you reach the top right. And so the first thing I want you to see is this lavender or purple colored line. And this represents the elevation of amyloid protein in the CSF. And so after that, maybe 1 to 2 years, we can identify amyloid on a PET scan. Now, some years later, we can identify tau. If we're looking at the CSF, that's probably about 10 to 12 years. And if it's on a PET scan, maybe about 8 years. That's still being worked out at our own center. That's the blue line. Now, the orange line, this represents the N of ATN. This is neurodegeneration, which can be seen as atrophy on an MRI scan, hypometabolism on a FDG glucose PET scan, or even some elevated biomarkers which we're still validating in CSF, cerebral spinal fluid, that look at neuronal injury. And then lastly, you have this green figure. And it's not really a line, but it represents the clinical syndrome, the clinical spectrum, the symptoms. And we start with normal down here, and then we move up to MCI, over here, and then eventually to dementia. And the reason it's a figure, not a line, is because if people are at higher risk for cognitive change, they develop these symptoms earlier than those that are at lower risk. And so this figure, this green structure, really represents cognitive resilience, which I'll talk about later. And while this figure looks very clean and pretty, the reality is Alzheimer's disease is more heterogeneous than that. And so we do know that there are going to be variations, but the really key thing to take away from this is that the first protein, the first biomarker that's abnormal is amyloid. And so amyloid is central to Alzheimer's disease, and it goes by many names. Beta amyloid 1-42, beta amyloid, amyloid beta, amyloid, it's all the same thing. It's an abnormal product that comes from a normal process. And so this figure here, the bottom right, represents a neuron, the cell surface of a neuron. And so right in the middle of that lower part, I'm trying to circle it right now with my mouse, is a purple colored figure, which is an amyloid precursor protein. It's a surface protein. We all have this in our brains right now. We carried it on in evolution because it serves a useful purpose. When it's cleaved by a normal protein enzyme called alpha secretase, those little subunits, the little proteins that come from that, they serve a purpose. They actually lead to neuronal health. They lead to synaptic health, the connections between neurons. But when an abnormal protein cleaves it, and that's beta secretase, it leads to abnormal protein subproteins called amyloid. The little peptides form oligomers. The little oligomers form fibrils, and then eventually you have these nasty, sticky plaques that form outside of the brain cell. And so these beta amyloid plaques are necessary, but they're not sufficient in the progression of Alzheimer's disease. So amyloid is not only a part of the disease process, but it increases one's risk for developing Alzheimer's disease. It also increases one's risk for just developing cognitive change. But again, it's needed, but not the whole story. We also need tau protein in order to eventually have Alzheimer's disease and neuronal cell death. So in this figure here, you can see the neurofibrillary tangles, which are made up of tau protein inside of the brain cell, and then the amyloid plaques, which are outside. And you can see it in this part under a pathology slide, a neuropathology slide showing those tangles and the plaques. And in the past, we needed pathology and pathology slides in order to identify Alzheimer's disease. But now with our cerebral spinal fluid analysis and our PET scans, we can identify this in living people. But in the end, it's about symptoms. That's what matters most to us. If a person could have Alzheimer's disease in their brain, but not have any symptoms, we wouldn't fear it as much as we do. And sure enough, in multiple surveys, 2005, 2011 to 14, there's a certain segment of the population that fears Alzheimer's disease more than death itself. Now, at this time, we cannot modify or change these biomarkers, but there are things we can do to change our actual cognitive ability or function. And these things are mentioned in the news all the time. So I want to take a few seconds to let you think about what might these factors be, and are you engaging in any or all of them? Now, our center calls them the 6 brain health pillars, and we study them and their impact not only on Alzheimer's disease, but on cognition. And you can see here we actually have 5 of the 6. The first one is exercise right in the top, and then going clockwise, we have diet, and then we have sleep, restorative sleep, social engagement, and then cognitive engagement. The 6th one, which is one I think we all would benefit from more and more, is stress reduction, stress mitigation. So results from human studies, as well as animal models, suggest that health behaviors may improve brain health, conferring resistance and manifesting as slower cognitive change. Now, modifiable risk factors like these may be targeted for intervention to preserve our cognitive ability, our cognitive function. Now, numerous animal studies have looked at the molecular basis of these concepts like resilience and found that modifiable factors, in particular exercise and diet, promote structural and functional plasticity. In clinical research, in human studies, health behaviors have been correlated with measures of brain health. These are things like brain volume and hippocampal volume, the short-term memory center of the brain. But other studies even suggest that lifestyle health behaviors may play a role in cognitive trajectories, how our brain performs over time, and the rate of change over time. So healthy behaviors may actually delay the onset of cognitive decline and dementia, regardless of the disease happening in the brain, particularly Alzheimer's disease. Now, addressing dementia is a global effort, and the need to reduce risk factors has gained traction throughout the world, including the World Health Organization. So in May of 2019, the World Health Organization weighed in, and in this 50 to 100-page document, they say that risk-reducing interventions are in fact clinical interventions. They need to be present in the clinic as well as in public health. And I'm not going to go over the evidence profiles that you see in the bottom left here, although hopefully some of you had looked at them, but you can also see them in this next slide. Because in 2017, the Lancet Commission released their perspective on dementia prevention, care, and intervention. They updated this in 2020, which is what you see here in this figure. And what's nice about this figure is that in looking at preventing dementia, they have 2 key pathways. The first pathway, which is this top green box, is reducing neuropathological damage. So that's addressing elevated amyloid, elevated tau, vascular changes, inflammatory changes. The second pathway is increasing and maintaining cognitive reserve, which is just another term for resiliency, or as we use with our participants, brain health and a brain buffer. Now, how we walk down these pathways is really important, and that's in the first left columns here. And this is where it overlaps with the World Health Organization, and that's because these are evidence-based guidelines. I've broken this list down into 3 sort of categories. The first of which is optimizing your chronic health. So that's addressing and improving your diabetes, your hypertension, your obesity, your mental health. It's also about reducing damage or insults to the brain. So preventing head injuries, smoking cessation, if you can, reducing your exposure to air pollution, excessive alcohol, hearing impairment, loud noises. And the last thing are more proactive brain health promoting behaviors. That's frequent exercise, social engagement, cognitive engagement. However, for anyone who works in a clinic, we know that addressing behavior change is really quite hard. And so none of the guidelines talk about well, what motivates people to change? How do we motivate people to change? But there is this persistent idea that personal information, personal risk, may be that motivating piece of information that kind of pushes someone to address their health, to perhaps make some lifestyle changes. And this has been shown in the field of Alzheimer's disease research, in particular with genetic risk of developing late onset Alzheimer's disease. And that genetic risk, for many who have probably heard it on the news, is apolipoprotein E4. And if you have one of these alleles, you have a 2 to 3-fold increased risk of Alzheimer's disease. If you have 2 of them, you have a 12 to 15-fold increased risk. But it is a risk, it is not a guarantee. And so the field has looked at disclosing this information to participants and studying the impact, not only in how they receive this information, but what they do with it afterwards. And so the REVEAL study in 2008 came out with this publication that showed that those that had ApoE4 positive alleles were more likely than those that were negative to have Alzheimer's disease specific risk behavioral change 1 year after disclosure. Now, 7 years later, a study called Associations Between Self-Referral and Health Behavioral Response to Genetic Information came out. And they showed that individuals who proactively sought Alzheimer's disease genetic risk assessments were more likely to undergo testing and then use those results to inform behavioral changes versus those that were simply responding to genetic test offers. And then more recently, in 2018, a study came out called a long-term follow-up study on disclosing genetic risk information to promote healthy lifestyles in Finland. Now, this was an observational study looking at long-term behavioral and clinical effects after receiving an ApoE disclosure. They looked at 70 people in their 20s to 70s, so it was very broad, and they followed them for a little over 5 years. They did blood tests, anthropomorphic measures, and questionnaires. And what they found is that in people who are ApoE4 positive, they had made moderate health conscious changes in their diet, and they did have slightly positive long-term effects on their clinical parameters, in particular things like cholesterol panels. So these 3 studies in particular suggest that personal risk information in the realm of Alzheimer's disease may be that piece of information that empowers people, that motivates people to make some necessary lifestyle changes. So given that we know that amyloid is a part of Alzheimer's disease and increases risk for cognitive decline, why don't we share the results with our participants? And there are 3 commonly given reasons. The first of which is a lack of clear, individualized predictive power. So amyloid testing is not diagnostic of the disease. Its purpose is to identify pathology. So it's a risk, it's not a guarantee. And knowing your amyloid status does not tell us if or when you will develop symptoms. Yet, I do believe our researchers are getting closer to this. The second commonly given reason is there's no curative or disease-modifying treatment. So knowledge of amyloid doesn't change your treatment options. This point might become moot in June of this year if the FDA approves the first ever disease-modifying therapy called aducanumab. Now, this is a monoclonal antibody that's infused in the body. It goes into the brain, and it does effectively reduce or eliminate the amyloid in the brain. It is not a cure, and it does not stop the disease, but it could truly slow it. But until then, this is a commonly used reason. The last and most important reason is this potential increased risk of psychosocial symptoms. And so in particular, we're looking at the impact of disclosure on the individual participant. And specifically, we're looking at depression, anxiety, stress, a change in the sense of cognitive symptoms, perceived lifespan. But we also want to know, does learning your amyloid result change you? Do you engage and interact in society differently, with your family differently, with healthcare differently, and of course, in research differently? So while these questions persist, there are some that believe we're not ready to disclose amyloid. There are others that do think we're ready to disclose. And one of the commonly given reasons, and the one that's frequently used, is clinical trial enrollment. So as I just mentioned, pharmaceutical clinical trials right now are focused heavily on drugs that can remove amyloid in the brain. And so in order for that drug to be successful, you need to have elevated amyloid in the brain. And for true, proper, informed consent, we need to tell participants that that's the reason they can be in the study. So this is commonly being done. The second reason is that research participants want to know their personal data. So as a research participant's experience with Alzheimer's disease increases, as their time in research longitudinal studies increase, so too does their desire to know their own health and their own risk. And despite explaining the limitations, while their interest goes down somewhat, they still want to know this information. The third reason is that researchers believe there is value in disclosing. A national survey that was conducted on imaging researchers in Alzheimer's disease asked if they felt we should disclose. And the majority of people said yes, though they don't know exactly how to do the disclosure. But they cited reasons such as respect for participant preference. They also cited it may increase trust in medical research, as well as increase retention in our longitudinal studies. And the last reason is one I've been alluding to, which is amyloid an opportunity for motivating risk-reducing behavioral change? Is it that piece of information that helps a person make the decision to address other risk factors, even if it's not specific to Alzheimer's or amyloid? So as the prognostic value of our Alzheimer's disease biomarkers is further studied and understood, there really is an increasing need to communicate the risk conferred by these biomarkers to our participants. However, before we're able to do this on a broader scale, two things really need to happen. We need to understand how people react and respond to this information, as well as how to identify and develop best practices for the actual disclosure. So this is a table. Well, this is an empty table, which I'll fill in just a second. And it comes from a recent publication from our group that's currently in production. And there are centers doing amyloid disclosure. And so we looked at those and we summarized and identified three key considerations. The first one is ensuring participant understanding of the study. And what this means is really providing an educational session, providing more education really on the biomarker. What is its role in Alzheimer's disease pathology? What are the limitations of the testing? What does the test result actually mean? And what are all the potential outcomes in receiving this information? In addition to explaining the actual study, how are we assessing people's understanding of the study result and what's happening to them? So that really speaks to the second consideration, which is effective communication to participants. And so that's really determining disclosure. Who's the professional that's doing it? How are they interacting and engaging with the participants? What type of standardized language is being used? Are we using tools to help people understand, such as images? Are we asking participants what the result means? And really, are we encouraging multiple questions throughout the entire study, including the disclosure visit? And so the last thing is really focusing on safety, participant safety. So screening participants for significant anxiety, depression, suicidality before enrolling, continuing to follow them throughout the study and assessing those psychosocial changes. And then lastly, something that our center has advocated very strongly for is developing a safety plan if a participant is identified as having a negative reaction or higher risk, and providing more support so that they are cared for during the study. Now, for those of you that have been thinking, would I want to learn this information? What would I do? I do want to summarize for you the key findings from those studies, those centers that have already done amyloid disclosure in healthy participants. Maybe this will influence your decision. And I broke it down into those that were amyloid non-elevated and those that were elevated. So for those that were non-elevated, there's an overwhelming sense of feeling relieved. These individuals understood the meaning of their results, and they did not have any test-related distress or mood changes afterwards. However, this was the group that was less likely to initiate lifestyle change. And that's because their perceived risk was lower. So they have more time to make those changes. They can do it another day. Now, for those that were amyloid elevated, the response was mixed in learning this result. So some were surprised, others were expecting it. The understanding of the meaning of the result also varied. Some thought, I have Alzheimer's disease. Others thought, I'm definitely going to get Alzheimer's disease. And others understood that it was merely a risk. Some had test-related distress afterwards, but on average, that was not clinically significant. And the next bullet point I bolded because it's that important. There were no mood changes on a clinically significant level afterwards. There are people who develop anxiety 3 months later, but for all the studies that showed that, they returned to their baseline 6 months later. This is the group that's more likely to initiate lifestyle change. Although they have a lot of questions, they have a desire to learn their specific risk. How elevated was my amyloid? And what is my risk for developing Alzheimer's disease 3 years later, 5 years later, 10 years later? So we took this information and we asked the question, well, what do research participants think? More importantly, what do our research participants think? And so we developed the Alzheimer's Biomarker Survey. And so we collected data on over 300 RAP and ADRC participants who identified as Black or white. And the purpose was to gather information on who is the most likely to enroll in a biomarker disclosure study, what is their reason for enrolling in the study, and what are the potential outcomes when we give them a hypothetical situation in which their amyloid is elevated. We have here positive because that's how people often think of it. We don't use that term, and I'll explain that in a few minutes. But before I get to the preliminary results, I want to describe our participant population to you. So the average age is 65, but it ranged from 57 to 72. The median number of study visits was 3. And that's important because that means that these are fairly experienced Alzheimer's disease research participants. So they've been in the center for at least 3 years, possibly 6, because RAP does it every 2 years. They see their participants. And so that means that their knowledge level, their understanding of Alzheimer's disease, the science, the biomarkers, the risk is higher in general than the general population. We do a lot of community and participant events and share the results and publications with them so that they understand what it is exactly that we're doing. Now, the majority of people were female, 74%. 58% had a bachelor's degree or higher. 45% identified as Black and 55% identified as white, and 62% had a family history of dementia. So for a good many people, there's a personal motivation to learning this information and being a part of the research. Now, we worked with the UW Survey Center, had a wonderful experience. They reached out to these participants and conducted a 25 to 30-minute telephone survey. And a lot of questions were asked. And some of them dealt with these clinical vignettes, where we ask them a certain situation, we try to get an understanding of their response. I'm going to read that one particular clinical vignette to you, and I want you to imagine that you were one, a participant, and then one, a scientist asking the question. So let's say you're asked to join a study that would measure a marker in your brain that shows if you are at higher risk for developing Alzheimer's. The brain marker does not show if you currently have Alzheimer's or predict if you actually will develop Alzheimer's in the future. Although in this study you would learn your results, there are currently no medications to cure Alzheimer's or any medication to reduce your brain marker. We felt it was very important to be upfront and honest about the limitations of the study itself of learning your amyloid status. So knowing that, the question was asked, how willing would you be to enroll in this biomarker disclosure study? And you can see here in this figure, my mouse works, that 34% of people said somewhat, about a third said very, about 20% said extremely, and then 15 to 16% said not at all or little. So the majority of people are interested and or would sign up for that study despite the limitations. But then we also wanted to look at potential positive outcomes or motivating factors for why a person would want to learn this biomarker. So we asked the question, how important would informing lifestyle changes be to you as a reason to learn your brain marker results? And you can see here, 51% of people said extremely, 31% said very, 11% said somewhat, and about 5.7% said not at all or a little. So the majority of people do believe, at least in our center, that lifestyle changes is a meaningful reason or a motivating factor for wanting to learn this biomarker. We also have to look at potential negative outcomes, psychological distress in particular, of learning this result. So we tweaked the question a little bit and we asked, if you learned that your brain marker result were high and you're at higher risk of developing Alzheimer's, how anxious or nervous would you feel about this result? And you can see in this figure, this is more of a bell curve or a normal distribution curve. So 37% of people said somewhat, about a quarter said very, 12 to 13% extremely, and then again, 25% not at all or a little. So despite the fact that people want to learn this information, they feel like it will help them motivate to make lifestyle change, they are in fact going to feel anxious about that result. But the most important question comes next, and that's looking at very serious negative side effects or adverse reactions to this information. So if you learn that your brain marker results were high and you're at higher risk of developing Alzheimer's, how likely is it that you would have thoughts that you'd be better off dead, passive suicide, or consider hurting yourself in some way? And fortunately, you can see here, 81% of people said not at all, 9% said a little, 5.1% said somewhat, and 3.6% said very or extremely. So this was reassuring to us that 90% or more people are not going to have this negative catastrophic reaction. However, we have to take seriously the 3.6% of people that could. And that for us prompted us to really advocate for developing proper education and screening, because some people may not be fit to learn this information at this time, but also a safety plan. So if you are learning this information, making sure we're there to help people as they cope through some of this information. So we incorporated these findings when we developed our own amyloid disclosure study. And so in our study, we are in fact disclosing amyloid to healthy research participants. A few weeks later, we're also conducting a personalized lifestyle plan counseling session. And what we have aimed to do is really see how those two things in particular impact people's behavioral change, if it increases their study participation, what types of psychosocial changes occur afterwards, and then how can the process be improved? What works, what doesn't? That's the qualitative aspect of our research. So we are interviewing our participants, we're having them fill out surveys, looking at process as well. Now, one of the secondary outcomes or objectives of our study is to see how amyloid status and then other demographic factors impact that relationship. So our goal is to develop a safe and effective procedure for disclosing biomarker and really any dementia risk-related information to research participants. We do want to know what the effects of amyloid disclosure are on those outcomes, including long-term care planning and research study participation. So this slide illustrates the structure of our many visits in this study, and I'm not going to go over in detail each and every one of these, but I do want to highlight and emphasize a few things. One is that we're trying to meet participants where they are at, and so we're providing lots of education, lots of support, and we check in with them quite frequently. And so in that vein, in the recruitment part of it, we provide lots of educational materials so that they can really review and understand Alzheimer's disease, amyloid, and what the study is. So that's provided on paper, that's done on our website for digital purposes, and then over the phone. So we're trying to hit people with many different mediums. Now, visit one, which is our true informed consent, we are also doing clinical screening tools. We're utilizing them. So that's looking for depression, anxiety, and suicidality. And we have a lot of other research questionnaires that we have them fill out. That's our baseline visit. But we're also doing an amyloid quiz. We want to make sure that they've understood the information we've sent them and that we've really explained ourselves clearly during this informed consent. Now, visit 2 is the disclosure visit. So we're again doing a quiz to make sure there aren't any gaps in understanding, and we're still doing clinical screening as well as other research tools. Now, 1 to 3 days later after disclosure, we have a telephone check-in. We want to make sure there are not any remaining questions that need to be addressed. We also are beginning our psychosocial assessment through other questionnaires. Now, visit 3 is our personalized lifestyle plan counseling session. So again, similar questionnaires. We're also at this point hopefully motivating people to address lifestyle changes or what they can do and empowering them. We're also trying to look at qualitative things. So this is where we ask about visit satisfaction, ways of improving. Now, the next 2 visits are all telephone based. And again, they're looking at psychosocial change, checking in, providing support. The luxury we have is that after this study, they still are in the parent study of RAP. And so we will continue to follow them for years to come. And there are some participants in RAP who have been with the study for over 20 years. These are very loyal research participants, and so we have this opportunity to study long-term impacts. The other thing this figure doesn't show is that we have developed a safety plan if any of these measures are abnormal or at heightened risk. And we did this with the help of one of our geriatric psychiatrists to make sure we truly knew what our options were and the things that our participants may need. So I did want to spend a few minutes going over the amyloid disclosure visit because this is the most clinically relevant. And when we developed this, we did have in mind, how could this possibly go in a clinic setting? And so I break down the disclosure visit into 3 aspects: pre-disclosure, disclosure, and post-disclosure. And I'm going to show you some of the worksheets that we created or modified. So the first one is a pre-disclosure worksheet. And you can see in this top part, and my mouse worked, I could show you right here. So family history, that's a key one that we want to know because we realize that people who have a family history may respond differently than others to learning this result. The next box down, you can see the scores of our clinical screening tools as well as their quiz score to see which areas they might have been confused about. And then the bottom part is something we have found to be extremely valuable, this pre-disclosure question section. So these are 4 questions, standard questions that we've created or modified that are allowing our clinicians to tease out if participants are truly ready to learn this information. So we're asking about interim changes in stress, anxiety, mood, or life events, but then really, what is their experience with Alzheimer's disease? What are they worried about, or how do they feel about learning this result? These types of questions allow participants to open up and then allow our clinicians to determine if they're truly ready or not. Now, the actual disclosure is fairly structured. So when we share information, how we share information, this is sort of rehearsed as well as practiced in development. And so one of the things that we have learned is that standardization matters. It's really important that we're clear and that it's consistent across clinicians. And our clinicians are myself and 2 well-trained nurse practitioners who are very comfortable with disclosure. Now we're recording things, observations as the disclosure is happening, and that's part of the science. So we're looking at behavioral observations as well as reteaching, any sort of system issues that come up. If any certain topics come up, we want to record those as well. Now, the worksheet that we share with the participant is really important. And so this is one that we did modify from one of our collaborators at another center. As you can see here, if you can see my mouse, the first bullet is the date of their PET scan, but the next one's really important. It's straightforward, clear language. Your result was elevated or non-elevated. And below that is the meaning of that result to the participant, if it's elevated or not. And we read this verbatim to the participant. We want to make sure that the language we use is clear and concise, and then we give them time to process that and ask questions. Now, the post-disclosure is open-ended. It allows for the participant to ask whatever questions they have, express how they're feeling, and for us to answer anything that we can. We have 2 additional objectives of, as you can see in the first bullet point, teach back. What did your result actually show? Have we done this effectively? And then 2, what does it mean to you? This is the beginning of our psychosocial assessment. And this has been very valuable to us in getting feedback, not only on the process, but on how people are feeling. Now, terminology matters a great deal in something like this. And so we use the accepted phrasing of elevated versus non-elevated amyloid. We shy away from positive versus negative because that varies depending on the result you're receiving, the setting you're giving that, and really the type of, or the individual who is receiving that information. There are certain connotations with positive and negative. We do not provide the degree of elevation. We are not there yet in the science. We do use a very validated and conservative approach to determine elevated versus non, and that's based on a 4-point scale, 0 to 3, where 3 represents unambiguous amyloid binding. And so that's the only one that we use as elevated so that we feel confident in the result that we're giving. We also don't show people their own individual scan results, but we do show them a generic picture such as this one, so they at least can visualize what it is that we're discussing. The other visit that I wanted to share with you all was the personalized lifestyle counseling session. This is very rewarding as a clinician. This is our opportunity to really help people and empower people. I do envision it as something that we could do in clinic if we were given enough time. And so we break it down into review, goal setting, and developing a plan. And what I mean by review is we go over a person's medical history, particularly those aspects that are known modifiable risk factors for dementia. We circle them, we then ask them, what is your understanding of this? How do you feel like you're doing in this? We want them to really think critically about their health. We then also address those 6 brain health pillars. And then in the middle table, you can see, or column, you can see the recommendations. These are either national guidelines or center guidelines. And then again, we ask them, what is your perception? How are you doing in this? What is your rating of this? We really want to center the participant we want to put the participant at the center of this visit. We really want them to be driving how this visit goes. We're trying to empower them. We're trying to get them motivated, but we don't want this to be prescriptive. We want this to be something they believe in and they can do. And so once we've gone over this education and this review, we then use goal attainment theory. So then we actually use the SMART goal formula to develop the goal with them. We fill out this information. We are willing to do the grunt work. We want them to sit and think about it. And so we in clinic do this inherently. The SMART goal system is a very effective way of identifying the goal, defining it in measurable terms, being realistic about what you can do, and then making sure you understand, why is this relevant? Why does this particular thing matter to me? And in what time frame do I wish I can actually achieve this goal? And so once we have that, we use goal attainment theory to monitor progress. And that's important to us in the science part of it, because we want to show or see if there's actual objective interval change. And then from a clinical perspective, we want our participants to realize, even if you don't achieve your goal, any progress in that direction is meaningful and important, and you should feel good about that. And so this next slide shows a table that we created with the example of being less stressed. And in the red, that's something that we would fill out in the moment with the participants. And again, we would be doing that. Now you can see rating 0, that's your SMART goal. So that's what you wish to achieve. So in this example, that's 20 minutes of daily relaxing or meditation. And then what you're doing now is considered a -2. So that could be maybe 1 to 2 times per week of meditation. That's still pretty good. But let's say you don't achieve your goal and you're doing 10 minutes every day. Well, that would be a -1. And they are defining this. So this is something that they get control over. And if they're overachievers, well, that would be a 1 and a 2. And so they leave with this paperwork. We actually mail it to them, but they have this paperwork to fill out. We will ask them about it. But again, we really want them to believe in this. So if there's a different goal, well, then we'll work on that goal. They get to direct their choose your own adventure in that regard. But as the saying goes, right, the best laid plans of mice and men often go awry. And so like everyone here in the clinics or in research or whatever it is you do, we've had to pivot. We've had to adapt to the pandemic. And so we went from in-person visits to virtual visits. Now, our in-person visits started during the beginning part of the pandemic, and so it really went from a masked in-person visit to an unmasked video visit. And so I wanted to just highlight some of our observations and experiences with this adaptation. And so first, in-person is not really in-person. And so we were more than 6 feet apart. We had people at opposite ends of a table. Didn't feel like a personal clinical visit, it felt like a business meeting. And so that just didn't feel as personal. Having a face mask was not as personal, and people didn't really like that. And you can't touch someone when you're providing reassurance or comfort or compassion. And so that didn't feel the same. Now it's easier to build rapport in person, and partly that's because body language and just probably the way we're wired as people. But you can do that virtually too. And so our virtual visits, and I should say, we are probably the only center in the country that's doing virtual amyloid disclosure. I can't be 100% certain of that, but I can tell you there's no publications to date. So Dr. Clark is really paving a path here. And so what we've learned in virtual visits, the obvious one is people really like seeing faces. And so they felt like it was more personal, even though we were on a screen like we are now, to see a person's facial expressions really did matter. Another obvious one was that there's no travel time. And so people liked not having to drive into Madison. We all kind of liked not having to drive downtown Madison. We also, from a scientific perspective, increased our reach and our access to participants because we're able to go to rural Wisconsin. But the other really key thing that we learned is that there's certain comfort and safety in being in your own home when learning potentially emotional and personal information. So one of our participants said he was so grateful that he could turn off the computer and be in his home when he learned this information. He did not have to walk through a sterile hallway. He did not have to go through a lobby and see other people. And he didn't have to go through a parking lot to get to his car and to cry. And that was really important to him. Another one of our participants is a breast cancer survivor. And while the disclosure of cancer is much different than disclosure of an abnormal protein, that person said this process is very comfortable and felt that this was a good way of actually doing such an intimate disclosure. Now, we've experienced our fair share of challenges as well. So we've had a lot of connection issues. So even though we've increased our access to the rural parts of this great state, if you don't have a good internet connection, we can't disclose to you. We're not going to do this over the phone, and we don't want it to be glitchy. We don't want there to be pauses. This needs to be a fluid process. So that's been a bit of a difficulty. I call it multiple clicks, or our clinicians call it multiple clicks. It's clunky. To be in person, to have a folder and organize your sheets the way you want them and present them to a participant the way you want them, that's very easy to do. When you're using multiple databases, when you're sharing a screen and then determining when not to share a screen, that's harder to do. It can be done, but it required us to literally do it step by step and draw up a protocol. And then lastly, expressing emotional support. It can be done, but it requires more intention in using your hand gestures as well as your facial expressions. Now, I did want to share a case study of how we had to use our best clinical judgment to disclose or not. Even though this is science, there's a lot of clinical aspects to this. And so our study coordinator identified a participant as, quote, high risk. And that was partly based on the questionnaire, but also because our coordinator learned from the clinicians from the beginning, what are we looking for? What are we concerned about? And she had a very strong gestalt feeling something was off. And so she shared that with our nurse practitioner, who is an excellent clinician, and was able to tease out these concerns and hesitations during the pre-disclosure. And after that happened, the decision was made not to disclose. Our team met the very next day. We reviewed the case. We all agreed. Our PI, Dr. Clark, is a clinical neuropsychologist. She met with the participant, provided support, answered questions. That nurse practitioner followed up a month or two later. And to this day, this participant believes this study is important, is grateful to be in the study, despite not learning the amyloid result. And so we're trying our best to ensure their autonomy, letting them make this decision after true informed consent, but also balancing that with safety and making sure that this is actually the right thing for a participant. They really want to be good participants and be a part of science, but we really need to make sure that they're cared for as well. So this last table I'm going to show you is the future directions of Alzheimer's biomarker disclosure. And this again comes from our upcoming publication. So we've identified some key areas. Personal utility, this is what we're addressing now. Lifestyle change, long-term care planning activities. We have the opportunity to look at longer-term psychosocial impacts, so stigma, subjective changes in cognitive ability. We're always looking to improve the disclosure process, making sure people understand the biomarker result. Maybe the data will be slightly different, determining the duration and the type of follow-up support, studying the effectiveness of it in different populations or different settings. We will continue to look at the trust in the medical research, and then the actual type of information we share. We could potentially in the future share how long they've had elevated amyloid, other proteins such as the tau protein. But the idea of disclosure is not limited to amyloid or to Alzheimer's disease. And so this concept that disclosure could occur in other preclinical conditions is entirely plausible. So with that in mind, we have three ideas. One is that process matters. So establishing best practices and characterizing impacts is really critical before doing it in a larger scale. Blood-based biomarkers, it's not the future, it's here. We have blood-based biomarkers that we're validating in Alzheimer's disease. And as these tools become cheaper, more available, we need to understand how we're going to explain these things, how we're going to use them. And then lastly, disclosure in a clinical setting. So the best practices in research may not translate to the best practices in clinic. And once we do have those practices, who are we training to do them? How is this impacting the patient versus the participant? And then, of course, there's always policy implications. How is learning this information affecting health insurance, disability insurance, long-term care insurance? How's it affecting the healthcare system itself? What about stigma? What about discrimination? We have to identify these ripples from this and make sure that we've properly addressed them before really implementing them in a wide scale. So in conclusion, amyloid is a key part of Alzheimer's disease and can in fact impact cognition. Disclosure of amyloid to cognitively healthy people has been safe. However, it may encourage people to make healthy lifestyle changes. But really more work is needed on the consequences of disclosure and process. Our participants want to learn this information, and virtual disclosures have not only been done, but they are in fact effective. So I'd like to thank my team again, as well as our collaborators, Dr. Kosick, Janitis, and Bethhauser. And as Dr. Asano mentioned, here's a plug for my podcast. So if you have interest in what we're doing in the Research Center or caregiver topics, we have 90 episodes as of today. Thank you, everyone.
Great, thank you. That was a wonderful talk. And I'm just giving you a heads up, Nate, your next talk is going to be on how to give a talk. Because it was a beautiful presentation, wonderful slides, great story. So thank you so much.
Thank you.
We're going to try something a little bit different for today and unmute the mics for questions. We're going to see how that works. We're a little bit short of time and we have a number of questions. So I'm going to start with Farah for her questions. So Farah.
Hey, Nate, I want to second what Lynn said. That was just amazing and fascinating. You alluded to it at the beginning a little bit about if once disclosed, people might have questions about how long they can expect before they get symptoms or what their, maybe what the probability is they'll get symptoms. Is there any hope that eventually we'll be able to answer those questions?
Yes, Farah. So that's an excellent question. And so while it's still just a risk, there are studies that are out suggesting certain timeframes and risk factor and percent risk for developing the next phase and developing symptoms. Those, those smaller studies, they're at one center or two. And so as more of the centers are able to pool their data and have a better understanding of it, absolutely. And I don't think it will be too far away. I do think it'll be in the next few years.
Great. Thank you. Next question from Calvin Bruce. You're going to need to consolidate your questions, Calvin.
So I guess the one I'm most interested in is was the question of Huntington's disease, which came up a few years ago when testing became available for that. But in general, when you get information that the revelation of which is going to be complicated, and I'm thinking about BRCA testing for cancer and other sorts of things where we do have experience now in sort of being able to give patients information that then needs a lot or deserves a lot of explanation. And I'm just wondering if you've looked into any of those areas in developing your research.
The field itself has looked at this and is really relying on the experiences of these other studies, these other conditions to determine not only process, but other aspects to think about. The idea of stigma, the idea of how this affects family members, what types of things people need to consider. So, I mean, it is those prior studies that really have prompted that you can't just disclose. We cannot just make this a 23andMe or direct-to-consumer experience. We really need to understand what everything happens, how these ripple effects occur before we start doing it. And if research centers and healthcare systems aren't at the front of this, we're fearful that other private organizations will just start doing it without really understanding the consequences. And so I completely agree with you. This is much more complicated than here's a result, good luck, it's a risk. And so we really need to figure out, based on those other experiences, what other things do we need to look at and consider, and how do we address those?
Great, thanks. And so last question from Joe Bluestein. You're going to have to pick your favorite question, Joe.
Oh, my favorite question is like, what is the MIND diet?
Wonderful question. So that is a diet by Dr. Martha Claire Morris at Rush. It combines the Mediterranean diet and low salt diet, and then has some extra things about antioxidative effects. And so it really favors vegetables, fruits, lean meats, berries, nuts, olive oil, salmon, and avoids or limits red meat, as well as, sadly, cheese, and more than one drink a day. But the diet is more feasible than the Mediterranean diet.
All right, well, we are at just over 9, so I want to thank Nate again for a great talk. There's many other questions. I'm sure you can email Nate and get those answers, or perhaps listen to some of the podcasts and maybe the answers are in there. So thank you all for participating, and have a great weekend. Take care.
Thank you, Nate.
Yeah, thank you, everyone.
Bye.